consuming. CT colonography is very time consuming. Nobody wants to do it. There are only 1 or 2 or 3 people in my department. They are willing to actually look at them. Majority of the people, they don't even want to look at them. It's time consuming. But using these kind of softwares, it is much easier to find it. So the software will find you the lesion. You look at it, you say, I agree with the computer or I disagree with the computer. Therefore, computer give you sensitivity, and you as a radiologist will add specificity to it. This is the one that they say if the lesion is less than 5 millimeters, the risk of malignancy is almost 0. Between 5 and 10, very, very little risk, maybe still less than 1%. But these are the lesions that you have to find. Those between 10 and 2, because they have the higher risk of malignancy. It's one of those things that's size dependent. So visual colonoscopy, I think, in the GI oncology will play a bigger role in the future. And another thing in the CT I want to talk to you about is dual energy CT and spectral CT. This is a new thing. This is our new toy. It started in the practice back in 2006. This is 2018, so it's about a little bit over 10 years that this is in the market. And then now we have spectral CT. The number of the cases that people were doing is increasing by time rapidly. Workflow, it is very important. I usually look at everything from the business point of view. Things should be fast, should be quick, should be lucrative. If this is not lucrative, nobody would do that. So it will fail automatically. So you have to have a very efficient workflow for the patient, for technologists, for the radiologist, and for the archiving and informatics. So there are multiple levels of the workflow that you have to work with. If you want to bring it to your practice, don't jump into a big project. Do one little project at a time. You can. I have a checklist I'm going to give you. For example, you can use neuro department can use it in the brain. Start with easy stuff. Okay, so for example, you want to use it for oncology, do it mostly for detection of the lesion, and then later on add another thing to that. For the kidney, again, detection of the lesion can be used for. So it's like stepwise implementation of the dual energy CT into your practice. Another beautiful addition to this family is spectral CT. The spectral CT is not only 2 energy, but it actually detects the whole spectrum from like 50 all the way to 150, for example, kV, and then a lot of information that you can use it for. The specific application for oncology are 3 areas. One of them is for lesion characterization. So you see a lesion with the spectral CT, you would know it is calcified, has a lot of iodine, blood pool of it. There are many, many parameters that you can actually check. Another one is lesion conspicuity. With spectral CT or dual energy CT, you can find more lesions than regular CT scan. For the liver, it is very, very useful because many times you see these hypodense areas in the liver, and honestly, many radiology, they just call it cyst and let go, even in the cancer cases. But based on with CT, dual energy CT, you can kind of characterize it and say what that thing is. Another example of that. Look at this subcapsular region. Here, you on the 70 kV, you don't see any lesion, but when you look at the 50, which is actually more sensitive for iodine, you can clearly see these lesions on this one. The conspicuity is much worse. So there are good and bad things about everything. It gives you a higher contrast, radiation dose is lower, and even you can use less contrast for that. But then on the bad side, you have a little bit higher image noise. For image detection, so some evaluation of the lesions can be difficult. But I really like these kind of images. It is kind of superposition of the It looked like pre-contrast, but it's actually virtual pre-contrast. It is like getting the iodine signal out of this and then only looking at this study without the the signal coming from the iodine part of the study. So you can kind of put it on the top of each other and end up with a picture look like that, look like a PET scan actually. That's interesting. Same thing is, yeah, and then lesion characterization, of course. You can characterize lesions that are otherwise difficult. For example, you see a filling defect in this vessel here, and you have no idea what this is. Is this thrombus? Is this tumor? But with this, it's very easy to say. I mean, it's not very easy, but it is kind of easier because if you see iodine inside of this thing, this is a viable tumor. If you don't see iodine, this is not a viable tumor. It is bland thrombus. So I have a lot of application in HCC. HCC is one of my area of interest, so this is one of those things that we are using it a lot. For pancreatic cancer, detection and characterization is very, very useful. All these little lesions that we otherwise miss on the regular CT, contrast enhanced CT, we can easily detect that the conspicuity is much better. We can use it. Also, in the peanut pancreatic neuroendocrine tumors, it is very, very useful. As you see here, it shows the hypervascularity much better when you use this. This one is you see the cystic lesion in this area, but then when you look at the iodine map of it, you can kind of see that there was enhancement. For the bowel, probably the most important areas the evaluation of the GIST tumor and carcinoid tumors. You can see if there's any iodine inside of this lesion, and based on that, you can kind of get a better idea if this lesion, how this lesion is behaved. Especially if you treat the patient, then you can see the decrease in the iodine volume or signal coming out of this tumor. Therefore, the patient is getting treated. This is it is almost functional imaging because it will tell you early if the tumor is responding or not responding to therapy. Especially for carcinoid, we mostly use nuclear medicine, but this is one of those areas that we can actually use for it. Evaluation of the peritoneum always is a problem. Carcinomatosis, we are known to miss many carcinomatosis, especially small peritoneal or mesenteric or omental lesions in the abdomen. I personally like to use diffusion weighted images for evaluation of those, but this also is very, very promising for for evaluation of the peritoneal surface. Just for the interest of time, I'm just going to go very quickly through that. One area that is very, very is kind of new in CT and ultrasound as well as MR is looking at the texture of the tissue. This is new. This is like over the past, I think, 5, 6, 7 years. First time I heard about this was about 12 years ago, I heard about this, they're looking at the texture of it. But at that time, we were like kind of let go. We thought it's probably not going to be a big player. But no, it is a big player now. You can look at the texture of the tumor, see how it is. There are many new indices. Like one of those is get familiar with these things about kurtosis. And these are like basically a new terminology that we have to kind of get used to. The mean entropy, MPP, which is mean positive pixel value, standard deviation of each pixel compared to the rest of the lesion, skewness, asymmetry. These are the things that we pay attention. These are not easy to see with eyes. These are computer analysis, basically. It's mostly a mathematical way to evaluate the tumor. So we will see more of these in quantitative ultrasound and quantitative CT. Now let me just switch to the MR part. MR, multiparametric MR is the king. Multiparametric MR is here to stay. In CT, we have something really simple, enhancing or not enhancing. On MR, there are many things that you can check. You check the diffusion, you check the T1 value, T2 value, you do in-phase, out-of-phase, you do fat suppression, you check the iron, you can do T2, R2 star mapping. All of these give you the basically features of the tumor or the structure using all these different parameters. Analysis is now turning into a very, very complex, complex algorithm. And I think this artificial intelligence computer will play a much bigger role in future to evaluate all these different parameters that average radiologist may not be able to analyze all of them at the same time, processing it. And one example of that is, for example, using the contrast for evaluation of the portal vein thrombus. This is one of our major problems. Whenever we see thrombus in the portal vein, we don't know what we are looking at. Is this thrombus or is this like is a blunt clot? There are enhancement is one feature, but also DWI, in my opinion, also play a bigger role, a big role in evaluation of this. If the tumor is, sorry, if the tumor is showing a lot of restriction, but most likely this is malignant. In rectal cancer, we do MR almost on all of the rectal cancers for the purpose of staging. We do for local staging, preoperative surgical planning, preoperative radiation planning, restaging, and even ruling out recurrence. The learning curve is very, very fast, actually. This is most of the junior attendings, after about a week or two, looking at like 2, 3, 4, 5 cases per day, they feel more comfortable to read these cases, and they do almost as good as, I'm not going to say 100%, but almost as good as people with over 5 or 10 years of experience. We did it in a small study group in our practice, and we saw that the people actually are learning this thing very, very fast. Most likely, in future, we will use MR for locoregional staging and use the either whole body DWI or MRI for evaluation of the N and M staging. Anatomy is very easy to see on the MRI. With minimal distension, you can kind of see all the different layers of the rectum. You can see the tumor. You can see all the peritoneal surfaces. You can see nearby structures. You can clearly see the pelvic side walls. These are all the features that are surgically important. Anterior peritoneal reflex, you can kind of easily see it here. That's how sometimes seeing these things is very difficult by CT scan, but MR is the way to go. For example, this anterior peritoneal reflex. This is important for surgeon because surgeon wants to know should stay within peritoneum or go under the peritoneum. This is like one of the key features. You have to tell the surgeon ahead of time that where the tumor is exactly located. We have this multidisciplinary discussion group with the surgeons, and we learn a lot from them because they ask you questions. So, is this here or is this not there? So you look at it, oh, it is here. Or you say, oh, I'm not sure, but tell me when you open the patient how it was. And then you go back and see where this if you were right or wrong. Looking at all the pelvic and pelvic musculature is very easy. Levator ani, puborectalis, all these muscles in the pelvis can easily be evaluated by the MR. So these are the things. We have a checklist that we go through, and I'm sure that more and more it will be in future. We will use the MR for evaluation of the rectal cancer. Also, mucinous tumor are very, very white on T2. Even we can actually give the tissue characterization, tissue diagnosis for this rectal tumor. Lymph nodes are very, very easily can be evaluated. Nearby nodes, if there's a skip lymphatic chain, that can be detected. So these are all very, very exciting areas in future. Post radiation, you can kind of evaluate it. Like example here, and you can clearly see the pelvic nodes in the field of view. Also, the bone in the pelvis is on our checklist that we evaluate them. So let me just move very fast to the last part of my talk. PET MRI is here to stay. I was not a big believer in the beginning when PET MRI started because it was very, very expensive. But I'm seeing more and more places that are buying PET MRI, and this is a one-stop shopping. And PET and MR will compete with each other, and who knows which one going to be better. But most likely, these two will complement each other. So you get some of the information from the PET and some of the information from the MRI. Now, DWI looks like PET, honestly. PET can evaluate the tumor, the metabolic activity. It's a metabolic map of the body, and can probably give you, in one stop, you can find basically all them, give you the N and M staging, the systemic staging of the tumor, as well as can evaluate locally if the tumor is responding to therapy or not. PET changes before the MRI. Here you don't know where exactly tumor starts and where it ends, but here on the PET you can clearly see where it starts, where it ends. So this is PET MR is a winner. DWI, the last topic I want to talk to you about the imaging. DWI is I'm a big fan of it. DWI looks like PET. DWI look at the diffusion, the diffusion of the water molecules in the tissue, and PET looks at the map, the metabolic map, but they very much look alike. You can use the exact value of the ADC, which is mathematical calculation coming from the B images, DWI images. You can look at the exact numbers. You can look at the heterogeneity. You can look at the configuration of that. These are all important features that we use for this. In future, we will have a lot more DWI application. In Paris, last year in October, I gave a talk on DWI application in ovarian cancer, and that was well received. So always, whenever you look at the DWI and ADC, you also need to look at your T1 and T2. This is that's how it is. You have to look at all of them because there are artifacts that can be very misleading. T2 shine through artifact is one of the one that we have to kind of pay attention to. This is basically all you need to know about DWI for the time being. Three areas that we use DWI right now is for lesion detection, for lesion characterization, and also for evaluation of the monitoring of the response to therapy. Okay, so I think I'm running out of time, and I apologize for that. As my last slide, last topic, I want to talk to you a little bit about post-therapy. This was not part of our practice 5 years ago. 5 years ago, I'm confessing, I was not looking for these. These are new stuff. Immunotherapy can have a lot of complication in the abdomen. Can cause colitis, can cause hepatitis, pancreatitis, cystitis, myositis. These are things that you should be on your checklist. There are a lot of acute complication and chronic complication of chemotherapy. There are chemotherapy specific. Okay, example. This is an example of that. This is one of the immune therapies, and this patient showed diffuse colitis. Post-therapy showed diffuse colitis. So what we're going to call this? Infectious colitis? No, this is actually a complication of the chemotherapy. So there are a lot of those complications that are agent specific. For example, this one patient has pancreatitis after chemotherapy. This is pancreatitis induced because of chemotherapy. This patient received prednisone, and after like a few weeks, everything went back to normal. So these kind of stuff we were not paying attention before, but now these are important. This patient has cystitis during the course of chemotherapy. This is the immunotherapy-induced cystitis. So these are, like for example, in this case, you see periportal edema. This is a mild hepatitis, again, because of immunotherapy. Their sarcoid-like reaction is something that is well known. This is, sorry, this patient, this was a baseline, 3 months, and then 6 months. You see more adenopathy in this area. You don't know what this is. Is this metastasis or it is not metastasis? But then it resolves after 6 months. This was a granulation because of this was granulation of the course of the therapy. So it would be because of the misdiagnosis or overstaging if we didn't know about these kind of entities. So these are very, very important. These are, you have to have a checklist, drug-specific checklists. For example, you have to know the tamoxifen is calling, for example, hepatic steatosis. And also, people with tamoxifen, when you look at the CT scan of the abdomen, you have to check specifically for the pelvis to see if they're, because they are at the risk for endometrial cancer, for example. So every patient receives the chemotherapy, you have to know what the complication of chemotherapies are, have the checklist available to. This is just a quick review. Patient can have pancreatitis, can have cholecystitis, hepatitis, can have steatosis, pneumatosis actually can happen after chemotherapy. Fistulization, colitis, these can be common, that can be complications of chemotherapy. When I was in residency and fellowship, we didn't know much about this. We have to start learning all these markers. CA19-9, I didn't know about that when I was doing residency. Now we use these every day. We are using them. For every cancer, there are specific markers somewhere. Okay, so these are the list that you have. And if you want to specifically look at the GI, these are the markers that you have for HCC, for adenoma, for carcinoma, for gastric cancer, for GIST. These are all markers and genetic abnormalities that we have to kind of get to know that. Thank you very much. I think we talked about everything I needed to talk to you. The next speaker is going to be Professor Taouli. My dear friend will talk to you about RECIST. And anybody knows what this is? This is how we got selfie a long time ago. Do we have time for one question or no?
We'll just maybe move to the second presentation and let the questions for the end.
Okay.
Bachir.
Perfect.
Bachir Taouli va faire sa propre présentation. Ce que je pourrais dire, c'est que Bachir, je l'ai connu il y a 20 ans à Paris en tant qu'interne en radiologie. Il devait faire ses armes en France et le destin a voulu qu'il parte aux États-Unis. Donc il va peut-être vous dire un mot de son aventure outre-Atlantique.
Ok, merci Mustapha, bonsoir. Salam alaikum. Donc je suis vraiment très heureux. Je remercie le docteur. Où est-ce qu'il est là? Je ne vois pas. Il est où? Docteur El Fakir. Ah voilà, très bien. Et le comité exécutif de la Société marocaine de radiologie de m'avoir invité. Je suis vraiment très heureux d'être là. C'est une ville très sympathique que j'ai visité aujourd'hui. J'étais venu la dernière fois il y a 20 ans au Maroc, donc ça fait déjà un bout de temps. Je vais donc parler de... Donc je vais me présenter, donc je suis le docteur Bachir Taouli, je travaille à l'hôpital du Mont Sinaï, à New York, et je m'occupe aussi de l'imagerie du cancer depuis à peu près 3-4 ans à peu près. Donc je m'occupe de ce qu'on appelle une core, donc c'est une structure qui s'occupe de toutes les essais cliniques qui ont besoin d'imagerie. Donc on fait beaucoup d'évaluations de réponses tumorales, notamment RECIST et autres. Et donc c'est devenu vraiment très fréquent de voir des demandes par les oncologues. Donc je vais faire vraiment une revue rapide de RECIST et des autres critères. Okay, I'm going to switch to English actually. So. On peut avoir le diapo? Il faut que j'appuie dessus, pardon. Okay. So disclosures. So why is it important to assess tumor response? Because we heard this morning there's cancer is becoming really a major issue in a lot of countries. And there's a lot of demand also from oncology side for more imaging demand. And these patients also are receiving more and more complex treatments, so complex surgical procedures, complex local regional therapies, and also complex chemotherapy and complex biological therapies. So as radiologists, we need to know how patients are treated. So you really, when you read a case, you need to know what the patient has received. That's really important. Otherwise, it's going to be really not a good report. Also, it's important to remember that radiology is becoming an important endpoint as well. It used to be survival, for instance, a lot of papers 5, 10 years ago, and now looking at, for example, time to radiological progression is becoming really an important endpoint in a lot of trials. Just like to remind you how complex cancer development is. This is a picture from a paper from 2011. It's still valid actually today. Cancer cells evade and multiply by a number of mechanisms shown here on this picture. For instance, you have angiogenesis, tumor promotion from inflammatory changes in the microenvironment. You can also evade growth suppression, evade immunity. So all these really can contribute to make a tumor more aggressive and can also metastasize. So, and all of these targets can be possibly targeted by drugs. So this is what we call targeted therapy. So, and these targeted therapies are biological therapies. They're not chemotherapy. They're very different from systemic chemotherapy. Just to show you an example here, for instance, VEGF inhibitors, anti-CTLA-4, these are immunotherapy, immune checkpoint targets or immunotherapy. You can use, for instance, EGFR inhibitors, et cetera. So a lot of these can be really used. And as radiologists, we need to know what kind of drug has been used, if the patient is treated, and we need to know also the effect of the drug if possible. So the biological therapies, or what we call targeted cancer therapies, are becoming a big, big market now, especially in the United States. So as I said, these tumors really slow down the tumor growth, so they will not kill the tumor per se. They, for instance, will develop immunity against the tumor for immunotherapy. That's one example where you try to increase the power of the T cells, for instance, to go after the tumor, but the effect is slower than for regular chemotherapy. So RECIST evaluation in these drugs becomes obsolete, okay, because the effect on tumor size is delayed. So that's a really important point to remember. And also, we need new imaging markers for these drugs. So just to give you an idea about the market in the US, it's, as you can see in blue, this is the market for biological therapies. It's increasing exponentially over time. It's been assessed to be over $10 billion. So it's enormous, 10 milliards de dollars. So that's a huge market. That was back in 2010. It has even increased. And you can see that regular chemotherapy is more or less stable, slightly increased, and this is becoming the norm now in a lot of cancer patients to receive biological therapies. So I just want to say a word about cancer immunotherapy. This is a revolution with a big R, une révolution. So this is really becoming also very, very important therapy in a lot of cancers from head to toe. So it started with metastatic melanoma, but now it's been used in a lot of cancers like lung cancer, bladder cancer, liver cancer recently, renal cell carcinoma. So this is really becoming an important one. And again, as radiologists, we need to know how they work, when they were given, and things like this. So these consist in different modalities. For instance, monoclonal antibodies has been used for breast cancer, for instance, cancer vaccines, where you can take a portion of the tumor of the patient and develop a vaccine that's targeted against that specific antigen. You can also look at non-specific immunotherapies, which are mostly used these days, like checkpoint inhibitors, anti-PD-1, anti-PD-L1, or anti-CTLA-4 therapy. So again, here with cancer immunotherapy, there is a major difference with systemic chemotherapy. It does not directly target the tumor per se. It will target the immune system. So for instance, shown on the right, it will basically target the T cell to increase its activated against the tumor. And so the effect is really delayed, and there's no major side effects. There are side effects, but it's not really as major because it will target mostly the tumor cells. And there's less toxicity. So with this introduction, I'd like to go over some of the currently used response criteria in cancer. The standard ones is typically RECIST, so response evaluation criteria in solid tumors. 1.0, 1.1. And I'm going to talk about some additional criteria that have been developed over the last few years. Modified RECIST for liver cancer, EASL criteria, and also a little bit about immunotherapy criteria, which are becoming really more and more important. So just remember that RECIST, everybody knows here, RECIST assesses treatment response based on tumor shrinkage. So basically, it's a very simple question. The oncologist asks, is the tumor shrinking? Is it decreasing in size? Yes or no? Is it disappearing? Or is it increasing in size? So, and this is still adopted by all regulatory agencies, like the FDA. If you are a company, a drug company, you go to FDA for approval or the EMA, it still goes, most of the cases, by RECIST. So they want to see tumor changes, tumor site changes. Unfortunately, this RECIST, it underestimates local regional therapy when you do, for instance, treatment for liver cancer or for metastatic liver lesions, and also the effect of biological therapies because of the delayed effect. So thus, we need to look at other things. So enhancement, for instance, is an important one. We can look at density, for instance, for CHOI criteria, and you can look also for enhancement in modified RECIST. So just to give you an example, in liver cancer, we do a lot of liver cancer treatment in my institution, especially with radioembolization. So if you treat a liver cancer at baseline, which is, say, a certain size, typically, actually, if you do radioembolization, for instance, or RF ablation, the initial tumor has got to be larger, right? Because you really need to increase the target appearance of the lesion to have like a safety margin. And so the size will have no meaning, basically. So if you say a tumor has been treated, it was 2 cm, and now I see a treated area of 5 cm. If you use RECIST, then it's going to be called progression, and it doesn't make sense, right? So you cannot use RECIST anymore for these cases. And often the tumor increases because of hemorrhagic changes, et cetera. But of course, if you wait long enough, then the tumor will shrink and eventually disappear. Say if you wait 6 months after embolization, then the tumor will be gone. But we don't want to wait too long to say, hey, you're good. So you want to say whether the patient has been treated correctly at 6 to 8 weeks early on. You don't want to wait. So that was, how I can make the point about not using RECIST in these cases. And unfortunately, it's still in use in a lot of trials, believe it or not, even in liver cancer, because there's a lot of resistance from the FDA, for instance, from drug companies on this. So we really need to adopt this as stakeholders to really change the culture a little bit. So very briefly, WHO, this is the first historically published criteria back in 1981. So this is really at the beginning of cross-sectional imaging. So it's been a while. Well, not so long, but it started back in the 80s. And it's basically measuring bidimensional size of the tumor. So larger size and perpendicular largest dimension. We don't use this anymore. I mean, I see radiologists measuring 2 dimensions. We don't do that. I mean, even in clinical radiology, we're not giving 2 dimensions anymore. We're giving just a single dimension, but you could do it. So RECIST simplified the work for radiology, came in 2000, so a while after WHO, and it's been revised in 2009, so recently as RECIST version 1.1, so this is what we use now currently in most trials. So here basically you're just measuring a single size, maximum dimension of the tumor itself. You don't care about the enhancement, the no enhancement, the necrosis, you just go very binary measurement. I see a tumor, I measure it, axial measurement, do not measure coronal. I see people measuring coronal reconstructions, that's wrong. Should be measured on axial images. And you basically 1.1 will specify the number of target lesions, etc. You don't want to know all the details. It's all on the websites or on documents. So just to very briefly define target lesions. So target lesions are lesions you're going to be measuring. Typically with RECIST 1.1, it's up to 3 per organ, maximum of 3. Used to be 5, now it's 3. So if you have 3 lesions in the liver, 5 lesions in the liver and 5 lymph nodes, you got to be measuring 3 lesions, not 5 in the liver. So the largest 3, and you got to be measuring the rest of the lymph nodes 3. So if you have more than 3 lesions in one organ, then number 4 will become what we call a non-target lesion, okay? So non-target lesions are important, but they're not measured with RECIST. You just say there is a non-target lesion in segment so-and-so, but you don't give a size. I'm talking about the RECIST evaluation. So again, this is just a definition. And of course, any new lesion that's clearly a new lesion then has to be characterized as such. And you can say a new lesion in segment X or Y, and this will define progression. So this is the RECIST 1.1 response that you need to know, at least a little bit, to have an idea. So complete response is easy. There's no more lesion. I don't see anything. Good. Patient is in complete response, not treated, but not cured, but complete response. Also, a lot of people actually will integrate into complete response the normalization of the tumor markers in the blood. That's really important. If you have somebody followed for HCC or for ICC, for instance, you have to measure the AFP and CEA and make sure these are normalized as well. Stable disease, we'll define it at the end. So progressive disease means patient is progressing. It's not a good sign. It means you increasing by at least 20% of the tumor dimension, basically. So if you have 3 target lesions in the liver, you're going to be adding up. So 1 plus 2 plus 3, and you do a percentage change. Okay, if that's over 20%, that's progression. Okay, and very important also, that's a mistake that I see a lot. Progression is defined by reference not to the immediately prior imaging. That's really important, actually. And I see that mistake done a lot because as radiologists, we're always used to look at imaging a day you're looking at and look at the immediate previous, right? Everybody does that, right? I have a CAT scan today. Prior patient has 5 CAT scans, 5 CTs from before. I usually typically look at the most recent one, right? This is what we do all the time. But for RECIST, it doesn't work that way. So for RECIST, you have to look at the nadir. The nadir means the minimum size of the tumor. So if a tumor goes from 3, becomes 2, and comes back to 4, you have to compare with the 2, not with the 3. So the smallest one, okay? So that 2 is between scans, then this is how you have to remember. So partial response will be a decrease of 30%, and anything in between 20 and 30% will be stable disease, okay? I'd be happy to answer any questions about this. The other thing also for the progression, any new lesion will be considered progression. So it doesn't matter if the target lesions have changed. If you have stable disease for target lesions, but you have new target lesions, that's progression. So this is a summary table for how you define response, progression, stable disease. I'd be happy to share this table. I mean, this is online. And so I think an important point to make also, when we do, for instance, I'm an abdominal imager. I look mostly at abdomen and pelvis. Patients that cannot be cut in pieces, right? So patients have brains, they have chest. And so just remember, when you give an evaluation on your part of the body you're reading, just remember that a patient has maybe new lesions elsewhere. So that's really important. Sometimes I see reports saying complete response, which doesn't happen that often, or partial response in the abdomen, but then the patient at the same time has a new lung met or a new brain metastases, then that's a problem. So that means the patient is probably progressing. So just keep that in mind, that the patient is treated as a whole. And sometimes the oncologists are confused by the report because they get a report from CT to say partial response or stable disease, and then you get a PET CT report that says progression, and then sometimes they just get a little confused. So that's why you need to remember that. That's why we have to go as radiologists to the tumor boards. Okay, I'm sure you already have this in cancer centers here. We have to be present. We have to be there to explain and to make sure that they understand and go over, confusing cases and things like this. So this is just a typical example, liver mets from colorectal cancer with progression. So not only the target lesion, this is a confluent target lesion, has increased in size over 20%, but also there are new lesions in the right hepatic lobe. So now I'm going to talk a little bit. So we spoke about RECIST 1.1. It is not too complicated to use, but it has some limitations, but also it has major limitation you cannot be using it in local regional therapy and also in biological therapies. So just remember that. So now modified RECIST and EASL have been proposed only for liver cancer. So this is to be used only for HCC, carcinome hépatocellulaire. And this basically looks at only enhancement, okay? Because liver cancer diagnosis is based on enhancement. So if you treat the tumor whatever the size is, there's no residual enhancement whatsoever on CT or MRI, that's complete response. So we don't care about the tumor size anymore. So it makes a lot of sense. It's based really on the angiogenesis. So just a summary of the RECIST. So this is a liver cancer that's been treated with local regional therapy, for instance, chemoembolization. The black area is necrosis, and the white area is enhancing residual tumor. Okay, so this patient clearly is incompletely treated. Okay, so they need to be retreated. But if you apply RECIST here, you're gonna be measuring the whole tumor. Okay, you don't care about the enhancement. And it doesn't make sense, right? Everybody agrees it doesn't make sense. Why would I care about the whole tumor? I need to care about the enhancing component. So if this tumor was completely black, meaning completely necrotic, it will still be measured as a whole tumor, but it will be complete response with modified RECIST. So modified RECIST looks only at the enhancing component, okay? So maximum size of the enhancing component, and if you have multiple enhancing components in the same lesion, you have to add them up, okay? So that's a little tricky. I'll show you an example. And EASL, so EASL stands for European Association of Study of Liver Disease, so it's like the Liver Society of Europe, and then he came up with this WHO-like measurement of two sizes in the enhancing component. But we rarely use this, actually. We prefer RECIST. So now when we read cases of liver cancer treated with chemoembolization or local regional therapy, we provide the tumor size RECIST, so the large tumor, and we also provide the RECIST measurement if there is any enhancing component. So this is an example, again, a real example. Treated HCC with two components. RECIST will measure the whole lesion, and RECIST will measure the enhancing components only on the arterial phase and add them up. And then eventually you come up with a table like this, where just ignore EASL, and then if you look at RECIST, again, complete response, réponse complète, no more enhancement anymore on the arterial phase. Okay, so it's gone, it's black. Partial response will be at least 30% decrease. Progressive disease means progression, at least 20% increase in the sum of the diameters of the enhancing, of the viable target lesions, okay? And stable disease will be in between, I don't know. So why RECIST makes sense, right? But also we need to prove the point that it is better than RECIST, and it has been proven by multiple studies. One of them showed, at least two of them actually showed back in 2012, that modified RECIST is better than RECIST in predicting HCC outcome to response to angiogenic therapy, like sorafenib, for instance. Also, another study showed that in patients treated with chemoembolization, modified RECIST and EASL were better predictors of survival in HCC patients compared to RECIST. And also, significant associations were found between RECIST and survival. So clearly, it's more connected with the tumor biology. Thus, it's better connected with the survival of these patients. Limitation of RECIST sometimes when you have these treated lesions, well, with very heterogeneous appearance, you don't know where to put your cursor, you don't know what to measure, that can be sometimes difficult. And it happens once in a while where we don't know where to measure the enhancing component, and we just tell, and then we got a lot of pressure. We're in transplant center, actually, Mount Sinai. We do a lot of liver transplant, and in the United States, patients with liver cancer who get, patients with liver disease who get liver cancer get extra points to get transplanted more quickly. And then it's very important for us to give them the diagnosis of treated HCC or not treated, so that they get or they don't get the extra points. So we get a lot of pressure from the transplant coordinators to be really accurate on this. Another thing I want to mention quickly is image subtraction. This is really simple to do with MRI, and it's very, very helpful. So we do this automatically. So it's auto-sub on all the MRI systems that we have. We get subtracted images. Why is it important? Because anything that's been treated can become hemorrhagic. So that includes, any organ, but then, for instance, the liver. So this is an example of a large HCC cavity that has been treated with chemoembolization and RFA, radiofrequency ablation, and you can see hemorrhagic changes. You can't really tell if you look at the post-contrast images whether this is viable or not. It's hard. You do subtraction, and there you go. You see a black hole. This is complete response, okay? No question about it. Complete response by RECIST. Everything around is just noise. It's not important. So we have showed actually recently, last year, in about 61 patients with 97 HCCs treated with local regional therapy and explants. So all these patients had treated HCC, and then within 3 months got liver transplant. So we took the liver out, basically, and then we took the tumors and analyzed the tumor for viability. And then we looked specifically at complete tumor necrosis. And then we were able to predict complete tumor necrosis based on MRI with very high accuracy. As you can see here, AUCs of 0.810 to 815. And what's interesting is that mRECIST worked very well. So that means you can really use CT. That's the good news. But also, subtraction was very good at predicting tumor necrosis. And what's interesting about subtraction is that we can provide a necrosis percentage based on the reading that worked very well with the pathological endpoints. So you can see the correlation was excellent for 2 or 3 readers here. So basically, when you see subtraction, when you see necrosis or viability on imaging, we're very accurate compared to pathology. These are the areas under the curve. So I just want to talk for 5 minutes about assessment of, do I have 5 minutes? 5 minutes? Okay. Immunotherapy response, this is really a new topic. I mean, immunotherapy is exploding. I mean, we see new trials every week in my institution, and we get more and more demand. It's small at this point, but it's really increasing in terms of demanding, new response criteria for immunotherapy. Typically, we look at clinical changes, performance status, and things like this. Blood assays are not really great in terms of immunotherapy at this point. There's really no good marker of predicting response to immunotherapy. So imaging is going to be really key. I mean, you can't keep biopsying these patients over time. So really, imaging does whole tumor assessment, basically, and then you can really try to predict response. And again, here, the major difference with conventional chemotherapy is that the patients can become stable. So basically, the tumor will become stable over time. But also, what's interesting is that you can have new tumors while the patient is not progressing. So this is really a little crazy when you think about it, when we thought about it, but it's been proven multiple times in different tumors. You can have new lesions while the patient is responding, and it's been shown that in metastatic melanoma, that these tumors can correspond to infiltrative immune infiltrates, basically, so infiltrated T cells and things like this, and these are not tumor components. So WHO RECIST do not apply to immunotherapy. Okay, you can always use them, but it's not going to be accurate enough. It's been, like I said, tumor regression has been documented after initial progression. It's called pseudo-progression, pseudo-progression. And also, it's been documented to have response when you have new lesions. And for instance, this has been shown in metastatic melanoma. This is really one of the seminal papers, very important papers from 2009, where they showed the effect of anti-CTLA-4, ipilimumab, on metastatic melanoma, where patients used to die quickly, and now some people actually are cured, which is really miraculous. And then, so we need really novel immune-related response criteria for immunotherapy. So this is an example of a pseudo-progression pattern. This is metastatic disease to the lung and the pleura. You can see baseline tumors in the left pleural cavity. You see progression per RECIST 1.1 at time point 2 after initiation of immunotherapy with the new pleural effusion. But then wait a little bit, and then you do a time point 3. You verify these findings within 6 to 8 weeks, and there you go. Nothing, everything is gone. So this is a pseudo-progression case. It's been documented in different tumors. And the patient has been responding to immunotherapy. So there are 4 different response patterns for ipilimumab, for instance, for melanoma. So this is summarized here in this initial paper from 2009. You can have first case scenario in A, easy. Tumor shrinks completely or disappears, so that's clear response. But however, you can have also slight increase in size and a progressive decrease in size, decline in tumor size, okay? You can have also a strong increase in size, which is would be called progression per RECIST, but then wait a little bit, and the tumors will progressively decrease very quickly and then eventually disappear. So these patterns have never been described with other treatments. So the first response criteria developed for immunotherapy were called IRRC. They're not in use, so don't remember this. Not important, but I just want to remember, just show it to you for the sake of history. This is based on WHO, so it's two measurements, basically bidimensional. And the important thing here is that you're incorporating these new lesions into something called a total tumor burden. So this is something new, never existed before with RECIST or mRECIST. You have new tumors, you integrate them into the target lesions. And then you just continue measuring that over time. Now, so this is basically 25% increase, 50% decrease, et cetera. So they have some criteria kind of similar, although the percentages are different compared to RECIST. RECIST is 30% and 20, this is 25 and 50, so it's a little different. And then in 2013, so this is all recent stuff, they came up with IR RECIST criteria, which is basically take the IRRC and remove the second measurement, just one measurement, okay? So this is like RECIST applied to immunotherapy. It's been in use in few trials, and it's been really shown to be as good as 2 dimensions. And to complicate things, in 2017, the RECIST group came up with iRECIST. And this is probably going to replace all the immunotherapy criteria, probably, because RECIST group is powerful. They have a lot of lobby at the FDA and things like this, so it's probably going to be what's going to come up the norm for immunotherapy. So iRECIST stands for immunotherapy or immune RECIST. This is published in Lancet Oncology. If you can take a look. If anybody wants the paper, I'd be happy to send it to you. It's not validated. This is from 2017. This is not even a year ago. And here, the difference is that CR, meaning complete response, you get something called ICR, so immune complete response, immune stable disease, immune partial response, et cetera. And the complicated thing here is that you have the concept of IUPD, okay, or ICPD. So let me explain this. It's a little complicated. So basically, I spoke about this pseudo-progression. When you have new lesions initially after treatment, they will call this unconfirmed progressive disease. So progression non confirmée. I don't know how to translate that in French, probably the closest. So that means you have to wait 12 weeks, 6 to 12 weeks, and see whether those new lesions have resolved. And then you're going to call that either confirmed progressive disease or partial response or complete response. So that's the only little complication here. So this IUPD business confuses a lot of people. And obviously, we're going to be using this. It's going to be a little easier when you use this. And the difference, again, with RECIST here, 1.1, is that you reset the bar. So basically, you got a pseudo-progression. You got a tumor size at a certain point, and then you wait, and then you reset the bar. Means you go back to baseline. And then you can also have the patient has the chance to get another IUPD again, if that happens. So just remember, these patients get a lot of treatments before. So they get, regular chemo sometimes, or they get, sometimes they get second-line therapy and things like this. But it's becoming the norm now to treat first-line now with immunotherapy. So you really need to know about this. And this applies to target lesions, like you do for RECIST, and non-target lesions. So iRECIST versus, this is the new criteria versus RECIST 0.11, that's unchanged, listed here. So measurable, non-measurable disease, number of target lesions, non-target lesions the same. Nodal disease, meaning lymph nodes, is the same. Calculation of the sum of measurement. The definitions are the same also, so that makes it a little easier. So the 20%, the 30% are the same for complete response and partial response. The confirmation is important. The difference is this. So new lesions are integrated into the tumor targets, basically, okay, the target lesions. You need a time point after progression. So once you have a new treatment, you see progression, you wait, and you do another follow-up immediately within 6 weeks to confirm what is progression. IUPD is called IUPD, like I explained a few minutes ago. I need a confirmation for that. Okay, so just as the summary of the immunotherapy criteria, I think you need to remember one thing. If you want to remember one thing, it's iRECIST. I think this is going to be the most important, and the one that makes a lot of sense, and the one that's closest possible to RECIST. So we just need to integrate that, tumor burden. This is just an example from our, trials. This is a metastatic bladder cancer treated with anti-PD-1. You can see, sometimes, mixed response in certain areas, probably because of the concentration of immune cells in the tissue, in the host. So in this case, you can see complete response for the lymph nodes, right? They're completely gone. And then this tumor here, extrahepatic, has decreased in size a little bit, but has less enhancement, but is still present. These are two cases. So we just started actually like 10 months ago, a new trial with nivolumab for liver cancer. So it's basically for second-line therapy for advanced liver cancer with anti-PD-1. So we treated already about 40 cases. Actually, we're the largest recruiting site for this multi-center study. This is an example on top. This is complete response. So you can see this is an amazing case, actually. This patient had this very large liver cancer that was non-surgical candidate, non-transplantable. And after actually 2 doses, 2 injections of nivolumab, look at what happened. I mean, he's completely responded. So complete response, complete shrinkage, complete tumor necrosis, and he's been stable over time. This one is not as lucky. This patient had right hepatectomy, as you can see, with multiple lesions. Also got treated with nivolumab in a trial, and unfortunately got progression. So with liver cancer, actually, in our experience, we looked at about 30 cases. We did not see a lot of pseudoprogression, actually, for some reason, like this so for melanoma and other cancers. Just want to say very briefly one word about our current, ongoing research. We're interested in radiomics and texture feature quantification in liver cancer and other cancers. So this is an example, and this is actually an interesting idea where when typically, like not too long ago, when liver cancer came up with a certain size and the liver function was okay, you can do resection, right? So this is probably the best treatment you can have for liver cancer. Now, there's more and more thinking from surgical oncology and from oncologists and immunologists that maybe certain patients with increased risk of recurrence should get neoadjuvant immunotherapy. And this is what we're doing now. So we started a trial of neoadjuvant immunotherapy before liver resection. So patients basically get 2 or 3 doses of nivolumab every month, wait 2 or 3 months, and see what happens, remove the tumor, and see what happens. So this is such an example. This is a patient who had quite, sizable tumor at baseline. This is baseline, about 5-6 cm. It was really near the portal vein. It was really high-risk patient for recurrence after resection. This is the radiomics quantification we did at baseline. And then after 2 doses only of nivolumab, look what happened. The tumor is almost completely necrotic. So 95% necrosis. We saw some changes also in radiomics. And also what's interesting is that there was this perilesional enhancement, as you can see here, that corresponded to immune infiltrates on pathology. So clearly we can see that the tumor cells get attacked by T cells at the periphery of the lesion and inside the lesion, and it became really aggressive. It doesn't work all the way, but at least in this case, it was really a big success. And the patient was happy, the surgeon was happy, everybody was happy. Just want to mention also briefly, this is my last slide, that there are other ways to look at response. So what's important also, because these drugs are very expensive, some immunotherapy treatments like vaccines can cost up to $80,000 per dose, so it's very expensive. We've actually been doing some vaccines. Actually, we have a vaccine center in our hospital where they do vaccines based on the antigens, and it's very, very expensive. So it's very important in these cases to tell them quickly whether it's working or not. After 1 dose, if possible, or 2 maybe. And you don't want 6 months. You don't want to waste the money and things like this. So this is an example of an early evaluation. This is a patient with liver cancer that's been treated with radioembolization, and you can see we have been looking at quantification of angiogenesis with DCMRI. So you can really look at the flow and the perfusion quantification in the lesion. We can look also at advanced diffusion. In this case, we looked at IVIM diffusion, which is looking at multiple B-value diffusion. We're looking also at MR elastography, changes in stiffness before and after therapy, and then there's clearly, in this case, significant changes in flow. You can see the flow is almost gone to negative, and the ADC increases in this case. So this is an ongoing study, will be presented actually next month at the ISMRM. Okay, just to summarize, this was probably a boring topic for a lot of people, but I tried to make it a little bit more to the point. Imaging, you, as radiologists, are essential for assessing cancer response. So you really need to know the treatment received in the trial, if possible. You need to know also the criteria to use them wisely. RECIST has a limited role for biological therapies, but it's still being used extensively, but it's probably going to starts switching a little bit. MRECIST and subtraction are validated against explant and HCC. So if you have HCC response, you need to know about these criteria. And iRECIST probably would be used more frequently with new immunotherapy trials. So I'm sorry to go over time. I'd be really happy to take any questions. Thank you. Merci beaucoup.
Merci beaucoup pour la qualité des deux conférences. Et s'il y a des questions? Des commentaires, des questions?
J'ai une première question, c'est concernant le dual scan. Alors, on a l'expérience pour l'embolie pulmonaire, pour la caractérisation des lithiases, mais c'est la première fois que je vois sur les tumeurs, les cancers hépatocellulaires.
J'ai pas bien compris la question, pardon. C'est quoi la question? Ah, dual energy, OK. He's asking about dual energy CT. So he's asking about characterizing liver cancer.
For characterizing the liver cancer, if you want to use LIRADS, LIRADS has very strict criteria. We'll check for the enhancement, we check for the washout, we check for the capsule, and then size. For lesion detection, it is actually useful. In a very limited number of the cases that we did, we find more lesions with using dual energy spectral CT. So the number of the lesion that you detect actually is more. Also, we can evaluate the enhancement to a little bit better extent. How much it's going to work in the big population, I don't know. But we are finding more lesions. Now, finding more lesions is important because if you have, let's say, 5 HCC in all different lobes, this patient may actually go down on the list of the transplant. But if there's a single lesion, you can actually do radiofrequency ablation. So it definitely has a place. Definitely impact. Oui.
Alors nous, on a beaucoup de cancers du foie. On fait à peu près, je pense, 15 à 20 IRM par jour de cancer du foie, par jour. Hein. Donc, et on fait très très peu de scanners en fait, que de l'IRM. Parce que je pense que c'est plus difficile en scanner, mais c'est faisable.
Les critères RECIST, on les a appris depuis bien des années grâce à l'intervention du professeur Yves Menu qui venait chaque fois et par la même occasion on le salue et on commence à en travailler depuis bien des années. Mais il y a toujours des changements et qui sont bien sûr basés sur des études à large cohorte, etc. Et ce qui nous pose encore le problème, c'est les pseudo-progressions et vous en avez parlé tout à l'heure. Donc si vous avez un conseil à donner aux radiologues généralistes que nous sommes quant à cette erreur, quant à ce biais qui est les pseudo-progressions.
Alors, un conseil philosophique d'abord, que je pense que RECIST, il faut utiliser à bon escient. Il ne faut pas commencer à l'utiliser à droite à gauche parce que c'est dangereux, je pense. Et je pense que ça devrait être utilisé seulement par des radiologues qui font de l'imagerie du cancer, si possible. Donc dans les centres anticancéreux, je sais qu'il y en a 9 au Maroc, déjà ça c'est important. Et même dans un centre anticancéreux, dans la routine, c'est-à-dire dans l'examen clinique de routine, on n'a pas besoin d'utiliser RECIST parce que c'est tedious, ça prend du temps, c'est pas obligatoire. On l'utilise vraiment dans notre cas pour les essais thérapeutiques. Et donc là, par contre, c'est un formulaire différent, c'est tout un process en fait qu'on a mis en place depuis 3-4 ans. On se fait payer pour ça d'ailleurs, et on va utiliser un software en fait séparé qu'on vient de commander pour faire les lectures du RECIST. Donc je pense que c'est bien de connaître, mais c'est savoir aussi que les oncologues des fois ils venaient nous voir pour demander un RECIST comme ça, et on ne fait plus comme ça. Donc c'est tout un process qu'on a mis en place justement pour éviter les erreurs, pour que ce soit centralisé. Et alors, pour revenir à la deuxième partie de la question, à la pseudo-progression, ça se voit en immunothérapie. Ça peut se voir aussi dans les, certaines tumeurs, certains traitements biologiques, comme les anti-kinase inhibitors, sometimes, les cancers métastatiques du rein, par exemple. On peut avoir des lésions qui commencent à augmenter de taille. Mais alors, là, c'est très simple. En fait, il faut attendre un mois ou un mois et demi, 6 semaines, refaire un scanner ou une IRM de contrôle. Et si ça progresse, c'est confirmé. Si ça ne progresse pas, donc c'est une réponse relativement simple. Donc c'est vrai que des fois, ça peut être, ça peut se voir dans ces cas-là.
Justement, je rebondis sur cette pseudo-progression, c'est-à-dire ce flare-up effect. Est-ce qu'on l'a imagé? Parce que tu as montré une image de scan. On en a aussi quelques-unes avec cette augmentation, puis ça diminue, on attend. Mais est-ce qu'on s'est intéressé, est-ce que ça donne l'IRM dans cette situation-là, notamment en diffusion? Est-ce qu'on a une évaluation de cette progression?
Il y a très peu. D'abord, il y a très peu de data pathologiques parce que c'est important de savoir si ces tumeurs sont biopsiées. Il y a des data sur le mélanome métastatique, mais il y a peu de data. Par exemple, dans le cancer du poumon, il y a eu aussi des papiers sur la pseudoprogression, mais il y a très peu de data pathologiques. Et la plupart des papiers, bon, le cancer du poumon, on ne peut pas faire d'IRM en général, donc c'est du scan. Sinon, non, je ne pense pas qu'il y ait de data spécifiquement sur l'IRM de diffusion ou autre chose sur la pseudoprogression.
Il y a d'autres questions? Antoine?
Bonjour, merci pour cet exposé magnifique. Donc, moi, j'ai de l'expérience. En fait, on a une centre, on fait pas mal d'immunothérapie pour le cancer du poumon. La pseudoprogression, elle est presque exceptionnelle. Donc, on en a peut-être 4 ou 5 cas sur plusieurs. Là, on est à plusieurs centaines de patients traités. Et en fait, quand on regarde la littérature, c'est surtout l'état du patient. Si vous avez le patient qui s'aggrave cliniquement, et que vous avez des images qui progressent, c'est que dans la majorité des cas, c'est une progression. Et en fait, la pseudoprogression, dans le mélanome, elle est énorme, elle est très fréquente. Par contre, dans le cancer du poumon, elle est exceptionnelle.
Pour le cancer du foie aussi, on a vu quasiment très peu de cas aussi. Sur 35, on a dû en voir peut-être un. Aussi, on ne trouvait pas que c'était très fréquent dans le cancer du foie. Mais pour le cancer du poumon, je pensais que c'était moins fréquent que le mélanome, mais je pensais que c'était un peu plus de pourcentage. Mais je ne savais pas que c'était...
Ça représente moins de 8% des progressions.
D'accord. Oui, donc c'est quand même un pourcentage pas consistant. Ouais.
Un grand merci aux orateurs pour
merci.
cette... Dernière question, s'il vous plaît. Et puis on va passer à l'inauguration qui sera animée par Maître Dana.
D'abord, toutes mes félicitations aux orateurs et au panel de la discussion, et également à la salle qui a posé des questions très intéressantes. Mais ne partez pas parce qu'il va y avoir une conférence extrêmement intéressante du professeur El Fakir. Donc restez bien tous ici. Youssef, tout d'abord, on profite de quelques mots pour dire qu'on inaugure de façon officielle ces 18e journées de l'Association franco-marocaine de radiologie. Je me permets de féliciter le professeur El Fakir pour son dynamisme au niveau de la Société marocaine de radiologie. Et je dois dire que je n'ai pas eu l'occasion de voir un président aussi dynamique que lui. Les autres étaient parfaits, mais celui-là a été exceptionnel. Voilà, je voulais me permettre de le dire. Hein, donc, ce n'est pas du tout, de dérision vis-à-vis des précédents qui étaient d'excellents présidents. Mais là, on a eu l'occasion, pendant ces 3 ans, d'avoir un président exceptionnel qui a dynamisé la Société marocaine de radiologie. Et je me permets de le féliciter très, très chaleureusement. Et ce faisant, je lui donne la parole parce qu'il va nous parler de l'état de la radiologie africaine et des défis qui sont posés à la radiologie africaine. Et je lui laisse la parole.
Merci, mon ami. Mes remerciements, d'abord, je les partage avec l'ensemble des gens qui ont cru dans le délire le bureau actuel et qui nous accompagnent. C'est un plaisir de vous avoir. Et donc, les journées n'ont pas de valeur si vous n'êtes pas là. Et je vous remercie. Je tiens aussi à remercier l'ensemble des sponsors, sans quoi on n'aurait pas eu les finances pour être dans un lieu aussi agréable que ça. Je remercie bien évidemment tous les conférenciers qui ont fait le déplacement. Et voilà, je prends la parole pour vous parler. Je peux avoir le... Ouais. Alors, Le challenge actuellement, donc j'ai voulu sortir un peu du cadre scientifique pur, qui est bien présenté par mes collègues, et de vous parler un peu de l'actualité de la radiologie africaine, quels en sont les défis et quelles en sont les perspectives d'avenir. Donc finalement, je partagerai mon topo en deux. Le premier, c'est celui des défis actuels, et deuxièmement, qu'est-ce qu'il advient de la radiologie ou des radiologues à l'ère de l'intelligence artificielle. On replace un peu le sujet. On parle de généralisation des couvertures sociales, on en parle chez nous depuis quelques années. D'ailleurs, ça a été avancé. Mon ami, le professeur Moustapha Boubret, parlait tout à l'heure de la couverture en Algérie qui dépasse, je pense, les 32 millions sur les 37 millions que connaît la population algérienne, et j'en passe. Donc finalement, on est en train de généraliser une couverture sociale, mais le problème, c'est qu'il y a une inadéquation entre la couverture, c'est-à-dire la genèse d'examen, et ceux qui vont l'interpréter. Donc j'ai quelques chiffres. Alors, un exemple, par exemple, pour l'Égypte, ils sont 95 millions. Ils ont 5000 Égyptiens. Je parle des Égyptiens qui exercent en Égypte. Les Tunisiens sont 11,4 millions. Ils sont à 618 radiologues inscrits exerçant en Tunisie, sachant qu'il y a 200 à l'étranger. En Mauritanie, 3,5 millions d'habitants avec 32 radiologues, donc avec une activité mixte publique et privée. Le Congo, 5,1 millions, 58 radiologues. Sénégal, 15,5 millions, 50 radiologues. Pourquoi je dis ça? Pour placer un peu le Maroc. Alors le Maroc, on est 635 radiologues. Quelque part, on est à 58% de privé et le reste est public. Vous savez très bien que la plupart des radiologues sont axés un peu entre Kéditra et Marrakech. Et parallèlement aux radiologues déjà installés, il y a des formations académiques par les CHU. Et j'ai demandé à mes collègues ici présents, que je remercie d'ailleurs, tous les chefs de service de toutes les facultés de médecine du Royaume, m'ont donné un peu leurs chiffres. Vous voyez que finalement la formation n'est pas régulière. Vous voyez qu'en 2010, on produisait, entre guillemets, excusez le terme, 15 radiologues par an, puis l'ACME à 2013, et puis en 2016, on retrouve 35 radiologues de mise sur le marché pour parler un peu finance. Bon, finalement, on se retrouve avec une rareté des ressources humaines et contrastant avec une demande d'imagerie de plus en plus fréquente. On n'est plus dans une ère où on parle d'échographie, de radiographie standard. Tout le monde en parle de cancérologie depuis tout à l'heure. C'est de l'imagerie en coupe, c'est 600-700 images. On n'est plus à 30 secondes d'interprétation, mais quelque chose en body, un corps IRM corps entier ou un thoracope Doppel, c'est un minimum syndical de 15 à 20 minutes, avec la comparaison, etc. Donc finalement, on produit beaucoup plus d'images, mais d'un autre côté, les radiologues, ils ne sont pas plusieurs barrettes. La plupart des radiologues sont au maximum 2 barrettes. Donc finalement, notre rythme est le même. Et on a beaucoup plus d'examens pour le temps qui nous est imparti, et il y a forcément une adéquation. Donc finalement, on résume, c'est que de plus en plus d'examens, peu de radiologues. Sans parler des déserts des régions où il n'y a pas de médecins spécialistes, en l'occurrence radiologues, et aussi une égalité de performance entre les secteurs publics, privés, etc. Et, comme on le sait, comme on vient de le voir tout de suite, on a beau être le meilleur radiologue, on ne peut pas connaître tout ce qui se passe de la tête aux pieds. C'est pas normal. Et donc finalement, on a des connaissances assez moyennes partout, avec une certaine expertise. Or, la cancérologie ou l'imagerie demande de l'expertise, malheureusement ou heureusement, dans toutes les pathologies. Et donc, il va falloir trouver des éléments de réponse. Si vous permettez, j'en donne quelques-uns. Le partenariat public-privé, cher aux politiciens. Je regrette d'ailleurs que M. le ministre et le secrétaire général qui devaient être là ont été retenus pour des raisons professionnelles. Alors, le partenariat public-privé, dont on en parle depuis longtemps, il faut le mettre en action. Fini le clivage santé publique, secteur privé. Je pense que c'est très ancien. Et ce clivage n'a plus lieu d'être. On parle TPA, on sait très bien qui fait quoi le matin, qui fait quoi le soir. Et puis, la plupart de nos collègues ou de nos maîtres sont installés dans le privé. Donc, un aller-retour, je pense qu'il faut passer à une deuxième étape. Et c'est le malade qui est au centre et pas le secteur. Deuxièmement, il va falloir réfléchir à une nouvelle organisation de l'imagerie médicale à travers un projet professionnel commun utilisant les nouvelles technologies de l'information. Il faut mutualiser certains services. Ce n'est pas normal qu'un scanner ou une IRM, qu'ils soient en public ou en privé, fasse, pour un scan, il fait 4 malades jour. Ce n'est pas normal. Un scan qui ne fait pas 40 ou 50, il doit être fermé parce qu'il n'est pas rentable pour plusieurs considérations. L'IRM, la même chose. Là, on peut mutualiser entre services, entre centres, etc. Il faut partager le savoir et bien sûr, il faut le faire savoir aussi. Et pour ça, il y a une réponse qui apporte un élément de réponse. Et cet élément de réponse, c'est la télémédecine, sachant que c'est un élément de réponse qui est ponctuel, qui va accompagner, mais qui ne remplace en rien la radiologue, qui ne remplace en rien la formation. Et donc je regrette que la formation des radiologues a baissé. Je ne parle pas qualité, hein, je parle nombre. Et donc, je vous dis aussi, et mes collègues privés sont là, l'âge moyen du secteur privé au Maroc est de 59 ans. C'est un truc chronologique, c'est physiologique. On a beau travailler, il y a encore quelques années à tirer, et il faut qu'il y ait de la relève. Et malheureusement, la relève n'est pas là. Alors, qu'en est-il de la télémédecine? Je vous apporte l'article 32 de la loi sur l'assurance maladie en France, qu'on copie beaucoup de fois. La télémédecine permet entre autres d'effectuer des actes médicaux dans le strict respect des règles de déontologie, mais à distance, sous le contrôle et la responsabilité d'un médecin, etc. Comme l'ensemble de la télémédecine, la téléradiologie est un acte médical strictement encadré par les règles de la déontologie. Un téléradiologue n'est pas là pour interpréter un examen mal fait, et encore moins pour remplacer un radiologue qui n'existe pas. Il est là pour accompagner le radiologue qui a une expertise dans le thorax et qui a parfois un problème au niveau prostate ou au niveau os ou neuro. Et c'est ça, au fait, le partage. En 2 secondes, je pense que vous le savez, c'est un service qui produit des images. Ces images sont stockées dans un PAX qui est ensuite envoyé à un autre service qui a la compétence et la machinerie pour en faire une lecture et redonner le compte-rendu. Alors, qu'en est-il de la télémédecine en général à travers le monde et surtout la téléradiologie? L'Inde, champion du monde. Ça fait 45 ans qu'ils ont commencé. La première société hindoue est faite par... j'arrive du mal à lire ça. Au fait, sa femme, c'est des hindous qui vivaient aux États-Unis. Et à un certain moment, ils se sont dit que dès qu'on termine notre formation, on rentre au bled. Sa femme est cardiologue, lui est radiologue. En rentrant avec un écho-cœur normal, il pouvait faire son travail. Lui n'arrivait pas à faire de la radiologie parce qu'il y avait un problème d'électricité, etc. Qu'est-ce qu'il fait? Il revient chez son patron et il travaille, il fait un aller-retour, comme la plupart des collègues aussi. Alors à cet moment, son patron lui dit, écoute, je connais ta valeur, vous avez Internet, je vais t'adresser les données, nous on dort, vous êtes réveillés, faites la lecture et tu me l'adresses. Et ça fait 45 ans déjà. Ils sont le premier société de téléradiologie en Inde. Et leur objectif actuellement n'est pas le pays d'Asie qu'ils ont conquis depuis très longtemps, mais les pays africains et surtout les anglophones. Mais pas seulement. Je sais à travers M. le secrétaire général du ministère de la Santé que l'ambassadrice d'Inde est venue pour signer un contrat de télémédecine avec le Royaume. En Asie, ils le font depuis longtemps, mais ils en ont fait un projet phare et ils veulent que 2030 soit automatiquement téléradiologie parce que, encore une fois, un problème de ressources humaines. Aux États-Unis, plus de 500 compagnies, et pour parler finance, parce que c'est comme ça que ça se passe dans ce business-là, c'est au fait, ils disent qu'actuellement, ils sont à 535 millions en 2016 et que le Global Market prévu en 2024 va être pratiquement multiplié par 10. Bon, j'ai eu une discussion avec mon ami le professeur Bachir Tawil qui me dit que ça marche, mais le problème c'est la qualité de ce qu'il interprète. Et donc finalement, lui, il n'était pas satisfait avec l'équipe qu'il travaille. Et encore une fois, ce que je disais tout à l'heure, la téléradiologie n'est pas une interprétation d'une image, mais c'est des gens d'expertise qui mettent leur expertise au profit des autres. En Espagne, c'est essentiellement les Catalans qui sont maîtres en matière, c'est Inforad et Iberarad. Et connaissant Ramos qui en est le président, on bosse un peu sur un truc. Et à un certain moment, je lui pose la question, combien ils font de scans jours? Ils interprètent 500 scans jours. Je me suis dit quand même, les Espagnols ne tombent pas plus malades que nous, c'est pas possible. Et finalement, en demandant, tous les pays de l'Amérique latine, c'est eux. L'Uruguay, c'est eux. l'Argentine c'est eux, le Paraguay c'est eux, et j'en passe. C'est-à-dire que la langue et la téléradiologie, et c'est des gens qui ont la plupart une formation, c'est comme nous, le lien qu'on a ombilical avec la France, eux, ils l'ont avec l'Espagne pour la langue pour plusieurs considérations. Donc finalement, la téléradiologie supplée à l'inégale répartition géographique des radiologues et des experts en imagerie médicale, permet d'optimiser la prise en charge des patients relevant des soins d'urgence, également un excellent outil de formation médicale, initiale et continue d'amélioration des pratiques professionnelles, et elle est à la médecine ce qu'est la téléphonie et la télécommunication Internet sans entreprise, ça veut dire la solution que doivent s'approprier et adapter tout le pays émergent. Deuxième partie de mon paragraphe, c'est que on parle de rareté et aussi le taux de pénétration Internet au Maroc est parmi les plus élevés en Afrique. Hein. Juste, on est à plus de 3,5 millions en Maroc abonnés Facebook. Hein. C'est énorme. Alors, je vais vous présenter, ce n'est pas de la science-fiction. Je pense que tous, vous avez vos téléphones, etc. Et ça, c'est de la réalité. Hein. Celle-ci, c'est en cours, c'est un work in progress. Et là, c'est ça, au fait, la téléradiologie. Maintenant, on va voir un peu... Voilà, ça, c'est de la simulation. Et la téléradiologie, enfin, l'intelligence artificielle a été, en 2017 et 2018, le thème principal aussi bien au RSN que Vienne pour le Congrès européen. Beaucoup d'informations se sont échangées en ce matière. Et surtout, il faut savoir que les grands de l'informatique s'y sont mis. C'est Google, Microsoft et IBM. Et pendant très longtemps, la radiologie était tributaire de la technique, enfin de l'électronique. On était dans un truc mécanique. Depuis longtemps, tout le monde sait qu'on est passé à l'étage plutôt informatique. Et vous savez que quand vous changez un serveur, vous faisiez une reconstruction en 3 minutes, et quand vous le changez, vous pouvez le faire en 2 secondes. Et au fait, l'imagerie médicale est la partie de la médecine qui se prête énormément à l'informatique et ça. Et pour vous expliquer au fait c'est quoi l'intelligence artificielle, je vous passe ce sympathique caricature. Au fait, quand vous faites votre recherche, vous voulez partir à Lisbonne en vacances, vous faites donc la recherche, votre femme fait la recherche, et 2 jours plus tard, on vous adresse des SMS et des mails pour vous dire des prix intéressants à Lisbonne. Vous dites, hein, quelqu'un m'épie. Au fait, c'est ça, au fait, c'est l'idée. Mais non, puisque vous avez donné à la machine de l'information pour qu'elle vous le retourne. Et c'est ce qu'on appelle le deep learning. C'est au fait, on lui apprend, et quand elle apprend, elle vous retourne. Et c'est ça, au fait, la base. Sur ça, il va falloir lui donner énormément de données, et c'est ce qu'on appelle le big data. Au fait, c'est beaucoup de données et de l'apprentissage. J'ai quelques diapos que j'ai empruntés à des collègues, enfin de la firme de médecine, je ne vais pas les nommer. Là, l'intelligence artificielle, pour ceux qui font pendant très longtemps, je pense que le cœur, par exemple, ceux qui font le cœur, dès qu'ils terminent le cœur, mais il y a le post-traitement qui se fait pour le calcium scoring, le score d'Acadstan, puis pour l'IVA, la circonflexe, etc. Vous avez des lignes déjà préétablies. Pour ceux qui font le côlon, dès qu'il a ce qu'on appelle la colonoscopie virtuelle, le CAD, le poumon aussi. Et c'est ça, au fait. Ça, c'est de l'intelligence artificielle. Quand vous faites une colonoscopie et vous montrez un nodule, c'est parce qu'on lui a implémenté tellement d'images qu'il sait que c'est un polype pédiculé, sessile, pathologique, pas pathologique. Et là, ce que je voudrais vous parler de ça, c'est déjà amorcé par le professeur Taouli tout à l'heure, c'est qu'au fait, ce qu'on voit, nous, comme image, une lésion suspecte, arrondie, spiculée, etc., quand on l'extrait avec un âge, une identité, une ethnie, un mode de vie, quand on l'analyse et qu'on met l'anapathe et qu'on a une histologie qui va avec, ben on a fait exactement, on a fragmenté. Et ces données-là, ce qu'on appelle les radiomix, et c'est ça, au fait, ce que fait actuellement l'intelligence artificielle. L'image qu'on prend uniquement comme un 2D, comme une patate, une lésion spicule, etc., au fait, c'est un milliard de données. Pourquoi? Parce qu'il y a la taille, la densité, la prise de contraste, l'âge, etc. Et donc, quand on fait 1000 lésions comme ça, à 1001, l'intelligence artificielle vous dit que c'est fort probablement un granulome inflammatoire ou probablement un adénocarcinome de type, etc., avec probable mutation génétique. Pourquoi? Parce qu'on l'a tellement implanté, etc. La même chose, donc, voilà, la lésion qu'on voit classiquement dans une radiographie pulmonaire, un scan, et finalement, voilà ce qu'on peut lui apporter, c'est tellement de données, et on peut anticiper non seulement sur un diagnostic étiologique, mais sur ce qui est important en cancérologie, ce n'est pas le diagnostic, c'est le pronostic, et c'est ça le plus important. La même chose pour ceux qui font la prostate, vous avez des images qui est classé en fonction de la lésion, etc. Vous le classez en PIRATS, et quand vous le classez en PIRATS, connaissant l'histologie, le Gleason et le PSA, et on vous dira exactement de ce patient de quoi il a besoin, une radiothérapie, une curithérapie, une prostatectomie radicale, ou probablement on vous dira aussi quel est le pronostic. Pourquoi? Parce qu'on lui a donné des éléments. Donc finalement, l'intelligence artificielle qui cristallise les peurs, elle ouvre de nombreuses perspectives pour améliorer l'efficacité de la médecine et de précision. Les techniques d'intelligence artificielle devraient constituer un vecteur d'opportunité du développement d'une imagerie médicale en Afrique, à travers des projets collaboratifs publics-privés. Et on doit changer d'un simple consommateur à des acteurs de développement et de création de richesses. Et là, j'ouvre une petite parenthèse. La plupart des vaccins qu'on importe sont suisses. Il n'est pas dit que quelqu'un de Congo a la même épidémiologie que celui de l'Afrique du Sud, qu'un Norvégien. Et pourtant, on consomme la même chose. Et si on ne fait pas ça, on aura encore une fois des données nord-américaines ou européennes qui nous disent que cette lésion, ça ne peut être que ça. Pourquoi? Parce qu'on n'a pas développé, donc on n'est pas si différent, mais on a notre patrimoine génétique qui probablement ne répond pas à celui de Strasbourg ou de Texas. Et donc si on ne fait pas ça, c'est pour ça qu'il faut passer à une étape d'acteur et non de consommateur. Alors, c'est quoi le radiologue du futur finalement? C'est lui qui devra développer ses connaissances informatiques et algorithmiques, bien sûr l'anglais. Et ça, j'étais heureux de voir les résidents tous rester, parce que la médecine et toute la technologie passent par ce vecteur linguistique. Et il ne faut plus qu'il devienne un imageur, mais un intégrateur de données. Finalement, c'est ça, au fait. On n'est pas dans l'image, mais on intègre des données cliniques, anapathes, etc., sur un ensemble de données. Voilà un peu l'évolution de l'intelligence artificielle. En 2005, on faisait que le cœur, et pas bien, je pense que c'était un 16 au maximum, ou un 40. Voilà ce qu'on a eu un peu plus, les nombres de barrettes, on fait un peu mieux, et avec le futur, c'est de pouvoir analyser le corps entier en quelques groupes, mais avec une spécificité pour chaque organe, pour le crâne, etc. On va pouvoir travailler. Alors, question que se pose tout le monde, bien évidemment. L'intelligence artificielle remplacera-t-elle le radiologue? Je vous laisse quelques secondes pour réfléchir, je passe à autre chose, pour vous donner les messages clés. Il faut qu'on ait une nouvelle organisation de l'imagerie médicale avec un partenariat public-privé de haut niveau, gagnant-gagnant. On n'est plus dans les tiraillements. Le clivage secteur public-privé doit disparaître, il n'y a plus d'être. Il faut mutualiser les services et profiter de l'expertise d'hyperspécialité. Il faut développer la télémédecine qui est source de partage de savoir et de transfert d'expertise. Quelqu'un qui est installé à Goulmim et qui reçoit un scanner thoracique alors que lui, il est habitué plutôt au crâne. Et s'il est vu par l'équipe du CHU de Casa ou de Rabat ou de Marrakech ou d'Agadir, qui ont de l'expertise pour ça, parce qu'il y aura un expert qui ne fait que ça, qui lui apporte non seulement un diagnostic, mais une façon de compléter l'examen. Au fait, il lui donne un diagnostic, donc il rend service au patient. Et le diagnostic est pris en charge par le chirurgien qui sait ce qu'il faut faire, mais aussi il transfère les données, l'information, et c'est ce qu'on appelle une passation de savoir. Deuxième message, c'est qu'on doit s'approprier les nouvelles techniques de l'intelligence artificielle dans notre pratique radiologique, parce que c'est un vecteur de santé, mais aussi économique et intellectuel. Et surtout, et ça, un petit clin d'œil à tous les collègues universitaires, il faut adapter la formation des radiologues à la nouvelle génération. Il faut adapter la formation aux nouvelles données de l'informatique et de l'intelligence artificielle. Ce n'est pas permis qu'on ait encore à tourner 4-5 pages pour trouver où passe le nerf crural ou le sciatique poplité externe. Il y a des méthodes très intuitives, en cliquant, etc. Et tous les jeunes radiologues, même, sont habitués à cliquer. Donc ça fait partie de la nature. Nous, on a du mal c'est là pour témoigner, on a du mal pour voir qu'est-ce qu'on peut faire, etc. Mais votre petit-fils, il le fait avec une impossible, il a 3 ans, il est né. Et donc finalement, il faut qu'on s'approprie ces données-là. Et puis voilà la réponse à la question. Est-ce qu'elle remplacera le radiologue? La réponse, c'est que Oui, le radiologue qui utilise l'intelligence artificielle remplacera celui qui ne l'utilise pas. Voilà. Mais le robot ne remplacera jamais le radiologue. Je vous en remercie. Voilà, donc Monsieur Dana est parti. Oui, il est là. Ben, c'est à vous de clôturer.
Alors nous n'allons pas clôturer les journées parce qu'elles ne font que démarrer.
On est d'accord.
On clôture la journée. La journée a été riche, la journée a été dense avec des communications très intéressantes. Et j'ai plaisir à voir des fidèles des journées franco-marocaines qui sont toujours là, c'est toujours les mêmes qui viennent avec grand plaisir, avec des plus jeunes aussi qui viennent égayer un petit peu pour l'atmosphère des plus anciens. Voilà, et nous sommes très heureux d'être ensemble et je considère que nous allons encore passer 3 très belles journées ensemble, le vendredi, samedi et dimanche. Et donc on va continuer à être présents dans cette belle salle. Et je remercie encore une nouvelle fois Youssef El Fakir de cette magnifique organisation.
Voilà,